Thanks very much. It's been a while since I've been to a resilience meeting, so I kind of thought I knew what the opposite of resilience was. I'd always assumed it was fragility, but I actually Googled it this morning and came up, there's a couple of antonyms which came up, which was, one was spiritless, which was interesting, and another was being inelastic. So I have a kind of a slightly different take on it now. But I guess that just illustrates the wonderful diversity and imprecision of English as a language. But we have to live with it and work with it. So the talk today is about the Refani studies. The 3 studies have been mentioned. So an introduction about the consortium, the studies, and then the current work which is ongoing to synthesize and interpret the data. So the consortium was led by Action Against Hunger and also involved very heavily Concern, Emergency Nutrition Network, and ourselves at UCL. It's great. In the room we have Mohamed Jelly, who was the study coordinator in Somalia for UCL, Jeremy Shoham from ENN, and ENN led the Niger study, and from Concern, various people involved here, of course, including Kate Golden, Austin, and others. Funded by DFID, and the programs were funded by ECHO. So we wanted to increase the evidence about the impact of cash-based interventions on nutritional outcomes in humanitarian contexts. So our research question was, overall, at this time we were calling them CTPs, or so cash transfer programs, but we would now call them cash-based interventions, as these things change. Can they protect nutritional status in a range of crises contexts? And we had a range of secondary questions too. We developed a theory of change about what happens within the household when they receive a cash or voucher transfer. And then at the bottom it goes through to what happens to the cash. It comes through to basically, do people spend, save, or possibly reduce economic productivity? Now, the next part of the theory of change looks at what happens if, for example, there's an increase in expenditure, and that expenditure may lead to expenditure on consumables, which could be food, so we could improve food security, and that could lead, in the end, to a reduction in the risk of current malnutrition. Alternatively, people may choose to spend it on services, which could be, for example, health services, and that could lead to improved health-seeking behavior and lead to a reduced infections and also, perhaps, to an improved resilience. I guess for us it's quite easy because we're looking at resilience against developing acute malnutrition. So it's a fairly simple, straightforward concept, luckily. So the 3 studies, one was in Pakistan, which was led by ENN and with the field partner Action Against Hunger. Then there was one in Niger, which we were involved with together with Concern. And again, Concern and ourselves working on the one in the Afgoy corridor, looking at IDPs. So a little bit more about the study sites. So we tried as far as possible to allow generalizability or comparability between the 3 studies. But as you can see there, for example, there were some differences of opinions about which particular age group could be focused on in these study contexts. So the study interventions in Niger, the pressing question that came from the country was about the timing of the cash intervention. So in Niger, it was in response to an annual hunger gap. And the question was, if we started the cash transfers a little bit earlier, would that help households become more resilient to the risks during the rest of the season? So it's about giving the same amount of cash over a longer period of time, starting 2 months earlier. So that was the Niger interventions that we were comparing. In Pakistan, they were able, with some more flexibility in the funding, to look at 2 different cash interventions, one with twice the amount of cash than the other, and also a fresh food voucher. And in Somalia, we were able to compare a control group who didn't receive the package with an intervention group. And the intervention being $84 per month per household, and non-food item kit and free drinking water. So those were the study interventions that we were comparing in the 3 sites. The study designs, so we all used cluster randomized trials. In Niger and Pakistan, they were randomly allocated, whereas in Somalia, it wasn't possible to do random allocation. So it was a non-randomized cluster-controlled trial. So this is an example of what the clusters actually look like. So looked like. This one's from Somalia, so a Google Earth map with the intervention and the control clusters labeled up there in different colors. So in this case, the clusters were very close to each other. They were juxtapositioned camps, whereas in Niger, at the other end of the spectrum, they were villages which were a long distance away from each other. So what happened when these different types of cash transfers were done? So in Niger, what we found was that there was no detectable difference in household expenditure at end line. And this wasn't particularly surprising, because if we see here, remember the intervention there was just a difference in the timing. So by the time of the last distribution, which is the end line survey, the houses in the intervention group receiving the modified cash were actually getting a slightly smaller amount of cash per month. So that household expenditure dropped a little bit. Conversely, in Pakistan, you can see where there was an actual no cash control group, we can see that household expenditure did improve. So we see the bold results have a positive statistical result. And we see that with standard cash and double cash, there was an improvement in household food expenditure. And it was nice to see that also resulted in an improvement in household diet diversity. In Somalia, we saw an improvement in overall, or an increase, I should say, in overall household expenditure, and also an improvement in household diet diversity. So looking good. This is just a diagram or graph from Niger where you notice that there was no overall improvement in household expenditure, just to show the impact of the intervention on household food security. And we can see that there was a difference over here, that this is when the intervention began. And for these first 2 months here, the intervention group was getting the cash transfer, which had started earlier, and the control group wasn't getting it. So you see there that household food security did significantly improve at that stage. But then when both groups started to receive the intervention, there was then no significant difference. Okay, so household expenditure has improved, diet diversity has improved. What was the outcomes? So here we have sorry about the size of the figures, but this shows the baseline prevalence of global acute malnutrition. It's worth noting that it was much higher at baseline in Pakistan, and sort of intermediate in the other 2 locations. At 6 months, i.e. after 6 months of intervention, we see that in Niger, the prevalence has basically remained unchanged. So despite receiving cash and other interventions which were ongoing, there was no impact in either group. We see no change in the prevalence. And I'll talk a little bit more about why that might be in a moment. In Pakistan, we see that in all groups, there was a marked decrease in the prevalence of GAM in all 4 groups, including the control. And also there was a fall in Somalia, but was the intervention significantly positive? And we see that in Niger, unsurprisingly, there was no difference. The intervention did not affect the prevalence, whereas in Pakistan, we see that we do get some positive results here. So in Pakistan, we see that, that there was an improvement in those receiving the double cash intervention, not the single cash intervention. In Somalia, we measured it in a slightly different way. We weren't looking at prevalence, we were looking at the incidence of malnutrition when measured using mid-upper arm circumference, or edema. And there we were able to calculate the HR, the hazard ratio, which basically tells you whether children were more likely to develop low MUAC. And the hazard ratio shown here was non-significant, so no impact of the cash on the incidence of low MUAC in the Somali IDPs. So we are left with the positive results on prevalence in only one of the arms that we tested, which was in Pakistan, where they received the double amount of cash. At 12 months, unfortunately, that effect had disappeared. So while the Pakistan result was positive in the double arm cash, and also you'll see, of course, in the food voucher, there was also an increase in the mean weight for height. By 12 months, there was no measurable impact. So this is just a picture to break up the tedious tables of a child having their MUAC measured by a community health worker in one of the IDP camps in Somalia. Secondary outcomes. So looking specifically at children, we can confirm, as well as there being an increase in household diet diversity, there was also an increase in child dietary diversity. And also, if we look at morbidity, one is the very high levels to start with, but two, we see no intervention effect on morbidity. One of the reasons we might have not seen a change in the prevalence of global acute malnutrition in either of the arms in Niger was this, which was just using collating routinely collected data from health centers on malaria. We see there's a large seasonal spike over here. So here we have the baseline measurement, end line measurement, and this large seasonal peak in malaria occurs just before the end line. So it may well be that it was the malaria morbidity which was contributing to the lack of improvement in global acute malnutrition. Now, one of the more exciting findings was that in Pakistan, not in Somalia, but in Pakistan, they demonstrated an improvement in stunting in all of the three groups. So there was an improvement in stunting and weight for height, for height for age in all of the study groups in Pakistan. And very excitingly, that result persisted at 12 months as well. So we're at the stage now within the consortium of trying to agree what all of this means. So what I'm going to present now is our particular take, the UCL take, on the conclusions and recommendations that we can draw from these three studies.
I'll have to have you just speed it up a little bit.
Yep, okay, here we go. Right. So it's effective. Cash interventions can be effective in some contexts at reducing acute malnutrition, but in other contexts, it's not. And that finding is consistent with what's out there in the development literature and other results which have come out recently, such as from the MAMOUT trial, from the paper by Grelity recently showing that it can improve recovery from SAM. So yes, sometimes it works and sometimes it won't. And that's not surprising given the multiple causes of acute malnutrition. Unsurprisingly as well, we see that in Pakistan, there was compelling evidence of an improvement in stunting. As has been known acknowledged for decades, stunting is a great indicator of poverty. And so if you're putting cash into a situation for long enough and at high enough levels, it's likely that you will be able to reduce stunting. So CBI, cash-based interventions, are a useful tool in humanitarian response, but usually by themselves, they're not going to be adequate to achieve humanitarian nutrition and health objectives. So some of the very important drivers, such as WASH infrastructure, vaccination programs, are unlikely to be achieved by a short-term cash transfer to individuals. And we're still going to require sector-specific interventions to make these things work. And lastly, research in humanitarian contexts, such as the ones we've talked about, is important and possible given donor commitments and strong partnerships. So a big thank you from UCL particularly to Concern, who are project partners in Niger and Somalia, and of course also to their project partners, Action Against Hunger and Emergency Nutrition Network. Thank you.